Hello, my name's Christine. Welcome to another Education Team podcast. Today I want to talk to you about strengthening multidisciplinary discharge planning. It is my QI project and it's supported by Janice Bernardo, our frailty lead. So, about discharge planning. Why do we need discharge planning? As you all know that the hospital pressures are constant and the stream of patients that require PAH services are relentless. So good and smooth discharge planning is vital to the operations of our hospital. But more importantly, it will help patient prevent deconditioning. As their length of stay is reduced, it will also mitigate the risk of them catching another infection on top of what they are trying to recover from already. And ultimately, it will improve the patient satisfaction. But how does that affect us, our working colleagues? Well, if all that's going smoothly, then we won't get as pressurized, and we will also prevent us from getting burnt out and exhausted. And our morale, obviously, is going to improve because we'll have better job satisfaction. But ultimately, hospital will have a good stream of happy patients, happy staff, increased patient flow, more beds, and it's a win-win for everyone. So now we know that a good discharge plan is good for everyone. How are we going to get there? So let's look at it and break it down. So establish a predicted discharge date, and this is from the moment they touch our Princess Alexandra Hospital front door, and we're looking at ED here, and most of the time it's via ED. And once they're seen by doctors, there should be a discharge plan and to identify how and at what stage this patient will be suitable for discharge. So, and also we are looking at if there's any referrals that is required for specialty reviews, then we need to be doing those as soon as possible because everybody's busy. We want to get these patients seen by specialists as soon as possible so that we can move forward with the patient care plan and get them to a stage where they're medically optimized for discharge. And at such time that they're medically optimized for discharge, then the nursing team on the wards will be doing a discharge information form. It's called the DIF form, and refer them to transfer of care team if they need to assess their social requirements back in the community. And at all stages, as soon as the patient comes into our hospital, all professions should be thinking about using hospital at home, because ultimately to prevent our patients from deconditioning, to prevent them from catching further infections, they are much better at home. So if they can safely be treated at home, then let them do so. It is for the benefit of the patients, most importantly. So we all know that different patients will need different pathways when we look to discharge them from hospital. And we break them down here into three main categories with some subcategories for each of these pathways. So I'll go through them one by one for you. Pathway 0, this is the simplest and the most straightforward pathway. It does not need much intervention from us or from our transfer of care team or our social workers. They're basically patients that have come into a hospital, they have had our treatment and they are medically optimized for discharge, and they can return back to their home, being independent, or back to the care home or nursing home, wherever these patients come from, and then continue with their lives back in the community. So we have the 0A, which is back to their original accommodation and setup, or we have the 0B, which is back to the original care homes. Then we're looking at pathway 1, which is broken down into three subcategories. 1A is back to their usual place of residence or care home, and there are, or they can be for short basis of rehab before they return home for recovery. This is coordinated by the transfer of care team. So we're looking at DIF form being filled in to refer these to transfer care team to assess. Then we have the 1B. These are the patients that are discharged back to their homes and temporary accommodation or hospice on a new additional package of care. POC stands for package of care. Or the 1C, which is back to the original care home placement with increased level of support. The next one is 2. This one does not have any subcategories and is basically discharge coordinated by the transfer care team. So they will receive our discharge information form and they will assess the patient and discuss this with our doctors, nurses to see what is the best approach, and these patients tend to be sent to discharge to assess bed in the community. So if you're thinking about possibly a temporary care home or St. Margaret's or Herts and Essex or Bishop Stortford and so on. So they are temporarily going to a community bed to continue with their recovery journey before they get assessed in the community for the next step and usually back to their home. Then you have the discharge pathway 3. This is the subcategory of 3A and 3B. These are patients that have been assessed and considered no longer safe to be at home by themselves or even at home. So this requires multi-level communication between doctors, nurses, family, social worker, PTOT to mutually agree the best approach for these patients. And they will identify the care home that is suitable for this particular patient, and the social worker will then need to assess the affordability status, whether it's going to be state funded or privately funded, and they'll be going to a new care home or nursing home. For our end-of-life patients, they will be 3B, then they'll be going to a care home / hospice, or for a new admission to be back in the community with comfort and their family around them. Now, what is the differences between a nursing home and care home? Care home is basically a residential home with carers looking after our patients in the community. Whereas a nursing home will have carers and nursing professions looking after patients that has medical needs, usually with EOL patients or patients that have got particular wound or catheters or insulin or medication or stronger medication that needs administering in the community. So they will be assessed and be deemed suitable for a nursing home rather than a care home. So I'm going to list several scenarios just to break down the different pathways for you. So we have Mrs. Patel, 79 years old. She was admitted with pneumonia. She's now medically stable, but still have mobility issues and fatigue. So she lives alone and is cognitive well. So she was assessed and they decided that because she's still not fully recovered from her pneumonia, she's better suited with a bit of short-term re-enablement package at home, just to give her a helping hand before she gets all her strength back. So she's going to be visited by carers every day to assist with her activity of daily living, and OT will assess her at home with the necessary equipment just to get her to recover easier. So her pathway will be, in this instance, 1B. If you've guessed 1B, then you're absolutely correct. Mr. Thompson, being the second scenario, 83, is recovering from hip fracture. So he's not yet safe to mobilize independently at home, and he requires physiotherapy and support daily activities. So he was then transferred to a community rehab bed, so probably somebody who lives in Essex, for example, and transferred to St. Margaret's for a rehab bed, or lives in Hertfordshire, transferred to Herts and Essex for a rehab bed for another 4 weeks, where he will receive professional care in a community, semi-community setting, and before he returns home. What do you think this pathway is? So if you guessed 2, you're absolutely right again. Mrs. Connor, 90 years old, has advanced dementia and was admitted following a fall. She is medically optimized, but unable to return home due to significant cognitive and physical decline. So she's discharged to a nursing home for long-term care. A social worker completes a financial assessment and supports the family in choosing a suitable placement. So we talked about that a little earlier, and if you have guessed this to be 3A, you're right again. So our final scenario is Mr. Ali, 68, has a late Parkinson's disease and was admitted with aspiration pneumonia. So he requires palliative care and complex medication management. So he is discharged to hospice with specialist palliative support. The discharge involved coordinating with the hospital, with community nursing, with specialist teams. Obviously, I haven't mentioned written family here, but all this has to involve the family and if possible, the patient as well, and to make sure that they have the comfort and the right place for them when they leave our hospital. So if you guess this pathway to be 3B, you're right again. So I touched on from the front door, all our colleagues should be thinking about hospital at home. And these are the services that our hospital at home team can provide patients and look after patients in the home. And there's quite a wide range, as you can see. But there's one thing to note, that if the patient needs to have finished their course of IV antibiotics, the hospital at home team will not be able to support 4 times a day due to the frequency. So once the IV antibiotics starts reducing in frequency, then these patients can be considered for hospital home as well. And do note about the different phone numbers for each region where the patient lives, and you can find that out by the patient's address, and do check the GP address as well. So these are the scenarios where hospital home will not be able to support. Do make a note of those and enable to refer a patient to hospital at home. This will be done by your ward consultant to the hospital at home consultant, and between their conversation, referral, and the hospital at home team will confirm acceptance, and do check with them to make sure when they can have the resources to start this patient care in line with when you can discharge the patient. So we have a discharge scenario here. Mrs. Taylor, 78, admitted with pneumonia and discharged after clinical improvement, so medically optimized for discharge. So she was discharged with different types of medicines, including antibiotics and diuretics. With unclear new medication instructions on discharge summary. I highlight that because at times, because we're so busy, the discharge summary may or may not have the relevant information, comprehensive information that is relevant to the patient at time of discharge. So, and also the pharmacist was not able to review her completed medication. So her daughter usually manages her medication, but unfortunately on the day of discharge, she was not able to attend and accompany her mother when she was leaving the hospital. So Mrs. Taylor returned home with the dosage, but then she misunderstood about the dosage and timing, and then she went back to her old regime and went back to taking too many diuretics, and then she became dehydrated. In 72 hours, she was readmitted with AKI. So where can we learn on this? So medication reconciliation and clear communication is absolutely vital to ensure that the patients have the right medication, right dosage when they leave. And do involve the carer and the family. In this instance, although the daughter cannot be present, we could give the daughter a call knowing that she is responsible for her mother's medication and care. So do remember to communicate everything to the carers and family where appropriate, because a lot of the times the patient's not going to remember everything you say to them because there's just too many things in their mind at the time of discharge. And do feel free to reach out to the community to have a timely follow-up and just to mitigate and check in on them that they are all okay as well. So the second scenario is Mr. Ahmed. He's admitted with delirium UTI. UTI most of the time causes delirium. Patient known to have early stage dementia as well, so that compounds it, with limited mobility and lives alone. So Mr. Ahmed was medically optimized after treatment of UTI. He was given twice a day package of care. However, the daughter believes that her father was just not safe to be at home because she felt that because of his dementia and his confusion, she's worried that what's going to happen to him in between the carers coming to see him, which I understand to be it's a fair concern. So this caused a delay because there's a mismatch between our assessment and our care pathway for him at the point of discharge and the patient's family's expectation of what their relatives should have when they return home. So what the lessons learned here is, because obviously due to this mismatch, the patient couldn't leave because, it's not safe. So the lesson learned here is that early transparent communication with the family is essential. So although we do our assessment and the patient could present one way in the hospital, returning back to their environment may cause them additional confusion and worry for the family. So discharge decisions should consider both clinical readiness and social context and involve carers and family, as I mentioned, and just to tailor the appropriate flexible discharge pathway. So the next scenario is Mrs. Taylor again. She's got increased confusion, reduced oral intake and suspected UTI. She was mildly dehydrated with a slight raised temperature and blood tests confirmed she has an infection with AKI. She was given IV antibiotics, she was given fluids. By day 3, her infection was getting much better. She no longer has further high temperature. She was alert, she's eating and drinking adequately, and her renal function had improved. This is absolutely fantastic, good story. And she is mobilizing with her frame. So she was then discharged with oral antibiotics for 4 more days, and regular medication resumed and followed up by her GP in 1 week. Her daughter supports her, she lives nearby. So what is wrong with this discharge plan? Absolutely perfect. We have a happy patient. However, we can make it better. Mrs. Taylor could have been referred to hospital at home from day 1 or 2. As soon as her condition has stabilized and she is improving and known that her IV antibiotics is having a good effect. So a referral to the hospital at home team to continue her IV administration could have allowed her to recover in her own environment and then reduced her risk of catching an infection whilst in hospital. So do think about that every time you have a patient in this similar scenario. So discharge scenario 4, this is slightly more complicated. Mrs. Hudford, she was found collected by ambulance in Stansted Airport while she was en route to Spain. She recently moved out of her rented accommodation in North London because she wasn't able to sustain that kind of property, and she doesn't have any friends or family that could support her. So without a home and having some difficulties, she felt that she should join her family in Spain. But unfortunately, she became unwell in the airport and then she was picked up and brought to PAH. So this presents itself as a complex social challenge as well. So once the patient's medically optimized for discharge, we really do need to ensure this patient does have a right pathway back in the community or where she wants to be. So this discharge planning, as I mentioned earlier, need to be started from the beginning as soon as she's brought into hospital, engaging various different teams to help her. So what we need to be thinking about here is to highlight early multidisciplinary coordination, as I mentioned. And because she's out of area, she doesn't have a fixed address. and it will be difficult for her to get the funding or the support from Essex, for example, where our hospital is. So the policy in hospital is to engage housing social workers and the transfer of care team immediately, so to prevent prolonged hospital stay. And do look up the duty to refer policy as soon as possible, as this will give you the referral process and the guidance of what you should do when you have a out of area and a homeless person. So just to give you some jargon busting answers here. So I would advocate, and I continue to say, medically optimized for discharge and not medically fit for discharge. Because if you think about a lot of our patients come into hospital, they are presented with one particular or some particular issues, but they still have a lot of comorbidity issues. So they are not in definition medically fit, and fit is basically on whose perspective and what level is this patient considered fit. So medically optimized is a safer word and a more appropriate word to use, so do use that and convert. Discharge to assess, as you can see, and discharge to decision to admit, discharge to assess and decision to admit. When said quickly, it could be misheard, so be careful with those two. And discharge home to assess. Discharge home to assess is when the patient goes home and you have the professions like PTOT who will visit their home to see how their setup is and whether it's appropriate for them at that moment. Medication administration record, the MAR chart is something that we print out for patients going to a medical setting. Just please ensure that when you send the patient with the MAR chart, it is as up to date as possible. If you printed it at 3 o'clock and the patient leaves at 6, please ensure that your 5 o'clock medication is marked on the MAR chart. It can be done by hand. You might not necessarily need to print another one, but if you feel you need to print another one, do make sure they go with the most up-to-date information. Package of care, we know what that is. TTA, take-home medication. Frequency of care, you have the OD, BD, and so on. And fast track is basically an assessment for appropriate patients which are referred to fast track to get assessed for funding back in the community and whichever pathway they end up going to. DIF, as I touched on, discharge information form, which is filled out by nurses as soon as patients are medically optimized for discharge, and the transfer care team picks that up and carries on with their assessments and so on. GSF, Gold Standard Framework. These are the assessment for end-of-life patients, and once the assessment's done, it breaks down into a traffic light system. As you can see here, the red, the amber, and the green, and that basically allows our teams to identify how quickly we need to enact the pathway for the patient to return to community, if that is what they so wish. So the documentation that we send our patient with is extremely important. So medication check. On Alex Health, you need to go on to discharge medication and make sure that when you're sending a patient, it corresponds with what is listed on the discharge medication. You check it, you sign it to say that you have checked it. And then you have the discharge summary. Please, please, please make sure that everything that is required for the patient to be looked after and cared for are mentioned in that discharge summary. And I will put an example is if a patient has any wound care, please ensure that it's mentioned in the discharge summary plan by the doctors, because once you do the district nurse referral and you mention this patient needs wound care, it needs to correspond as it's mentioned in the discharge summary. So TTA list, if your TTA discharge medication is not within the discharge summary and it's in a separate list, please make sure you send that as well. Transfer letters, that is done by the ward. Respect, if the patient is not for resus, please make sure there's a hard copy of the respect form that goes with the patient, as the ambulance crew will be asking you for this. MAR chart, as I mentioned before, make sure you have one of those. Latest information when a patient is discharged to any other hospital or nursing homes. The yellow booklet, which is this one here, sometimes you have carers that will request a medication booklet. Those are particularly for patients who live in Hertfordshire. If that is requested, the yellow booklet, get the pharmacist to fill that in. Supplies, make sure that medication, wound dressings, catheter care bags, patients who need them are sent with them at least a week's worth of it, so they can have an uninterrupted care for these patients. And warfarin, anticoagulant, steroid booklets, you will find them in the TTA bags when they are supplied by the pharmacists. So primary care referrals, so you'll find 2 referral forms. The top one here, the front page, that belongs to Essex patients, and the bottom one here, as it says on the logo, it's for the Hertfordshire patients. Do check the patient's address and check their GP address as well to ensure that you use the correct regional forms. So the information that you need to have on here, it's pretty straightforward. Just answer the questions as it is. But the most important part is that when they ask you, why are you referring this patient to a district nurse? Please make sure you communicate as much detail as you possibly can to the district nurses. And make sure that your communication is reflected in the discharge summary. So there's no good saying to a nurse that, please look after this patient's catheter. But then what is the district nurse going to do? So you might want to include things like a catheter was inserted when they arrived in hospital on a such and such date. And do say that patient now has a long-term catheter. Then it lets the district nurse know that this is a long-term catheter and this patient will be in their books for long-term. Or the discharge plan would be for talk clinic, or it could be for the district nurse to talk once they have open bowels regularly. So please mention all that, because district nurse needs all that information that you know to look after the patient properly. Anything less than that, the recipient of poor communication will be the patient, because they will have lapse in care, and this is something that none of us want. So discharge summary to reflect referral, management plan, as I mentioned, mention any medication, anything else that you want the district nurse to help with. If there are medication administration, you will be required to fill in another form. There's a separate form for insulin, one for Hart, one for Essex. There's also a separate form for just in case medication. This is the palliative medication with the CDs and so on. So that's a separate document again. And both these documents, any medication administration needs to be filled in by the doctor and signed by the doctors. And that needs to be also identical to what is in the TTA list or the discharge summary medication list. Any variation will be rejected by the district nurse, and they will reach out to us to redo those again. So please make sure you double check everything. Okay, so discharge, there are other bits and pieces that I want to highlight in regards to discharge and smooth discharge. So some patients come to us with safeguarding concern. It could be all the safeguarding abuses, but it's worthwhile finding out what the safeguarding concern is in the first place. For example, a patient could come to us with self-neglect because they can no longer manage at home. Their house might be in an unsanitary condition, could be quite cluttered, and the ambulance crew has raised a SOVA for self-neglect. Now, that does not mean the patient cannot go home, but it just allows us to look at the scenario right from day dot and engage all teams to look at either sending companies like we can to go in and do a clean as soon as possible. Then it allows the assessment to be done and say, what do we need to put in place for her home, for her safe discharge back home if she is going home. So these things could be done right from the get-go rather than wait until medically optimized to do so. So by the time she's medically optimized, then everything would be ready for her or him. So provide patients, one thing to mention about the SOVA is just check with the social worker to make sure that everything is in place. Check with your PTOT team to make sure all the equipment that's necessary is in place before this patient gets discharged. Provide patient with clear discharge information, so educate the patient if you can. and also educate the carers and families who are involved with your patient. Now, medical photography. We all know that when a patient comes into your ward, you do a skin check, you do your purpose T assessment and all the other assessments in place, and you take photos of any areas of concern. And during the duration of stay in hospital, you continue to take photos of the progression of those areas of concern. But most importantly also is to take photos on the time of discharge, because that allows you to create a benchmark of what the conditions of your patient when they leave the hospital. It is useful for when, if for example the patient do have to come back, then you know what the wounds are like when they were discharged, say 3 weeks ago. And also if people in the community, carers or family or whoever that looks after this patient raise a concern that they have for example a Cat 3, and they wanted to know where they got that Cat 3 from, then you can have some photographic evidence at the time of discharge. So then you can report back accordingly. So important to do a verbal handover to care homes, nursing homes, hospital, because you want to ensure there is a continuation of care for that patient. All the important information that you know about that patient at the time of discharge will be important to the next group of people who's going to look after them. So please pass that important info across and communicate. Now, one thing I will highlight is that if you do have a patient that require a package of care at the time of discharge, do always find out the name of those carers and their contact numbers and how many times a day that care is happening and when is it starting. Why do I highlight that? It is most important, and it's happened many times, as you all know, is that transport might be late, and if the package of care starts at 6 and the transport turns up at 6:30, more often than not, that patient may not be safe to go home because nobody will be there to put them to bed or whatever that they need when they get home. So by knowing who the carers are, by knowing what the contact number is, you can quite easily give them a call and say, transport's just turned up at 6:30, they will be home at 7. Could you please push that care to later when they get home? So do ring the carers as soon as you know there's a delay to reorganize the time, because from personal experience, the carers tends to be quite accommodating and they can just move a few clients around for that particular incident and be able to accommodate a later discharge for you. Now, don't just take the name of the carer and say you can Google it, Google the contact numbers, because when you Google the contact numbers, more often than not that they're going to come up with several phone numbers, different offices. Then which one would you call? When you're really busy, you don't have time to call different offices to find this patient. So do get a phone number, get the name of the carers, and find out how often the package of care is and when is it starting, to make sure that the patient's discharged home with the carers coming to see them. So transport. So when you book or cancel transport, please ensure you give them that 2 hours lead time. So if you book 2 hours lead time minimum, when you cancel 2 hours ahead. Do ensure that sometimes when you give 2 hours ahead, they will still put on the cancellation website that it's been aborted. Do ensure that is not the case and get them to ensure it is cancelled, because once it's listed as aborted, it is still chargeable to PAH. So I don't need to say any more about be mindful of transport delays. If a patient is to be at home at 6, there's no good trying to book transport for 5 o'clock. It's not going to happen. Even booking at 3 o'clock may not happen. So book it as soon as you know. Sometimes it's worthwhile booking transport even before you have your TTA in your hands. As long as you know it has been requested for and it's on the way from the pharmacy, book the transport. Sometimes it's worthwhile doing that. Okay, so one thing I will highlight very importantly is about a patient going to a new care or nursing home versus going to an existing, their own care or nursing home. If they are going to a new establishment, it is fair to say that you need to ensure you don't lapse on the establishment's cutoff time. So usually their cutoff time will be maybe 3 or 4 or 5 o'clock. So make sure the patient gets there on time, because when the patient's there, they'll need to do a whole assessment, familiarize the patient of the environment and so on, settle them in. So it's no good asking them to turn up and then the staff, half of the staff in that establishment's gone home. But if they're going to their original care home nursing home, there is no cutoff time. Please do not ask these establishments what their cutoff time is if you know they are going back to the original home, because I will use a scenario as such that if the family decides to take their mum or dad to a meal in the evening and returns back at 8:30, would they lock the door and say he or she is not allowed to go home? That probably will not happen. So likewise, if they are discharged from hospital and you've done a full handover and the patients seem to have no further increase in level of care and they're just returning home, please then don't ask the care home nursing home what their cutoff time is. Okay? And where possible, use discharge lounge. There are criteria of patients who cannot use discharge lounge. For example, if they are confused, wandering and high-risk fallers, if they have infection that could deem other patients at risk. So those are a couple of scenarios, or bariatric patients. So those patients will not be deemed suitable for discharge lounge. If you've got patients who have got dementia and you feel that by the change of environment it's going to cause them to be unsettled, then please avoid causing them to be upset. So consider patients to go in wheelchair where possible. Every time they are sent by stretcher, there are higher likelihood of the transport not being able to collect them as the day goes on. So it is a lot easier, and there are more transport staff to take patients in wheelchairs than there are with stretchers. So I know sometimes you want the patient to go with comfort and so on, but if they don't have to be in a stretcher, do consider that. And also part of that consideration is to understand where is the patient going on the other end. Are they going to a upstairs bedroom? Are they going to a tight a room that has a tight corner and a stretcher is not going to get there? So do consider where the ambulance crew going to drop the patient off, and make sure they have the keys or they have the key safe. That way, if any of those doesn't work, you will find that your patient's going to turn around and come back. So as mentioned in the last bullet point, bariatric and sectioned patients do require minimum 24-hour notice to the transport crew. And that just shows you that everybody can book transport. All you need is the login details, the username, password. Every ward has their own. Just log in and use the transport booking website. If you're not familiar with it, you can, obviously, anybody can show you. It's quite easy to use. So signposting. You'll find that a lot of your wards have leaflets and pamphlets that we can give out to patients. A lot of those are support network that our patients can access back in the community. Find the appropriate one that you feel would be of interest to the patient. For example, if you have an elderly patient who's going home, lives alone, maybe give them a leaflet about befriending services, or maybe see whether they would like Meals on Wheels. It's about that human contact for them as well. Age Concern has a lot of support for elderly people too. And I touched on We Can does a lot of things. So do read those leaflets and see what is appropriate for your patients, and do refer them, because the more support they have in the community, the less likelihood that they will be coming to hospital with some injury or illness and so on. So Essex County Council have introduced an initiative where people who live in Essex can apply for free equipment that they may need following assessment. So these are just some of them, and you can reach Essex contact through this email and this phone number to register the patient for the necessary equipment that they may need. So safe discharge equal happy patients, and obviously it will prevent them from readmission. So every patient that we're looking to discharge, you're always thinking at the back of your mind, what do I need to do to prevent them from coming back into hospital? So you can imagine, none of us want to be in hospital, so let's help them to stay in their homes and in the community. So there's the QR code that I mentioned at the beginning. Please feel free to scan this one and answer the same similar questions, just for me to help me gauge how successful I was in telling you about the issues of discharge planning and how we can make that better. Thank you very much for listening to me, and do pause the video and give me your feedback on how you felt about this presentation, and look out for the next education team podcast, and you will find that on Alex Health. Do dug in and have a look. There are many topics that you can find and that you can look at, and refresh your memory at your own time, at your own speed. Okay, bye bye.